Hi, I'm John Seymour from the Peter MacCallum Cancer Centre and the Royal Melbourne Hospital in Melbourne, Australia, and unfortunately still in Melbourne, Australia, instead of being in San Diego, where people would have been gathering to talk about many things, including the 5-year update on the MURANO study. I suspect people will be very familiar. This is a randomized comparison of time-limited 2 years Venetoclax plus Rituximab in the context of relapsed and refractory CLL compared to what at the time was standard chemoimmunotherapy with Bendamustine and Rituximab. All patients have now completed treatment, median 5-year follow-up, and many of the elements for MURANO in this update that Arne and Carter presented were incremental. So there's still a very substantial benefit from Venetoclax. The primary endpoint was progression-free survival. That continues to be profoundly improved with the Venetoclax regimen. So the 5-year rates are now 37.8% with Venetoclax compared to no patients progression-free at 5 years after Bendamustine Rituximab. For the first time, the median can be defined with the Venetoclax regimen, and that median progression-free survival is 53.6 months. Now, remembering that's with 24 months treatment, so the majority of patients have a longer period under disease control off treatment than they were on treatment. There continues, to my surprise, to be an increasing overall survival benefit. At 5 years, that's an absolute 20% difference, 82% with Venetoclax to 62% with Bendamustine. And that's despite 80% of the patients after disease progression following Bendamustine then receiving novel targeted agents, predominantly BTK inhibitors. So to me, that says that there really no longer is a role for second or subsequent exposure to chemoimmunotherapy. Targeted agents, whatever your preferred targeted agent is, really should be used at first progression after chemoimmunotherapy. Now, minimal residual disease had been one of the themes of MURANO, and that continues to be the case. So taking the 130 patients who got to the end of treatment, the MRD status at that time point very strongly predicts for time to progression. So for those who are MRD negative or undetectable at the 10 to the -4 level at that end of treatment time point, their median PFS from there onwards is 39.7 months, compared to 27 months for those with low-level positivity, or only 4.6 months for those with high-level positivity. For the first time, we presented some data on serial MRD after completion of treatment. So now focusing on the 83 patients who are MRD negative at that end of treatment time point. Very encouragingly, 32 of those remain MRD negative. Perhaps optimistically, one of the questions out of this study was, will there be curative potential from Venetoclax combination? If there is, it will require a cohort of patients to remain enduringly MRD negative. Follow-up is still short, but 32 of the 83 have the potential of that very durable response. We'll need to keep following those. Now, of those who did convert to MRD positivity, the median time after end of treatment was 19.4 months. Remembering that's first low-level detectability of any disease. The time from detectable MRD to then fulfilling disease progression criteria was an additional 25 months. What we saw, as I mentioned, was that not all patients have converted, and there appears to be a diminishing rate of MRD conversion. But once MRD re-emerged, there was a linear and consistent rate of progression by IWCLL criteria, consistent with what we know that once disease is detectable at the MRD level, it inevitably progresses to be clinically manifest. There were no new safety signals at this time, and in contrast to the German CLL14 study, there is no hint of any increased risk of secondary solid tumours. The second element that was novel here is now retreatment data. One of the whole themes of time-limited treatment is keeping open the possibility of retreatment with the same Venetoclax combination at disease progression. And there are now 18 patients who have been retreated with Venetoclax. The median time off treatment was 2 years, so many of these had relatively short initial disease control to Venetoclax, but the response to second treatment is 72%. What we're also seeing is that those who attained a deep remission, so MRD negative to their first treatment, appears to be a prerequisite for attaining MRD negativity on second treatment. So numbers are small, but it looks as though a deep first remission identifies a group of patients who are destined to have the best response to second treatment with a Venetoclax-based combination. The second element that's very reassuring is if you elect not to retreat with Venetoclax, but go to a BTK inhibitor, there are now 14 patients who have been gone in that sequence, receiving a BTK inhibitor after disease progression following Venetoclax, and all 14 of those have attained a disease response, confirming, and there have been a few other series published, confirming that that sequence is a very effective option for our patients. The final novel element was looking at the biologic factors that determine the rate of MRD regrowth, or so-called MRD doubling time. And some of the usual suspects, genomic complexity stands out as being associated with a faster regrowth, but the strongest signal was by IGVH mutational status. So patients with unmutated IGVH had a much faster MRD doubling rate of 2 months, which was twice as fast as those with mutated IGVH, where the doubling rate was 4 months. So these biologic factors are beginning to emerge to identify those patients who have the most durable period of disease control after time-limited treatment. So the MURANO study continues to deliver, I think, very important clinical data and some emerging and informative biologic data that will be able to help us in identifying which patient groups are optimal for which choices in treatment, because we have a fantastic array of treatment choices for our patients available at the moment.